afternoon. So this is quite a broad-ranging topic, and it's a little bit complicated, sometimes more of its classification. So just bear with me, and we'll have a run through. The premise really, the outcomes really, I'm hoping is you'll understand that this is potentially an extremely serious disease that requires prompt diagnosis and prompt management, and unfortunately still in this country has a very high morbidity and mortality. So the title of my talk this afternoon is Acute Bowel Ischemia. How does it present and what should I do? So this is really the situation that sometimes general surgeons can be faced with. Dead necrotic bowel, and we know that even if we resect this bowel, our patients sometimes can do very badly. They'll certainly do much worse if we don't get to the bowel before it progresses to necrosis and perforation. So this is about prompt diagnosis and rapid management. So the definition here is a little bit clunky, but this is about as good as I could get. So intestinal ischemia encompasses a heterogeneous group of disorders. And I think that's important to emphasize because today I'm going to talk about a range of conditions. Some are often benign and some are often fatal. So it can be caused by processes which are either acute or chronic, and that's really all about the presentation of mesenteric ischemia. And it can arise from occlusive or non-occlusive etiologies, by which I mean a blood vessel, usually a big artery or a big vein, is either blocked as an occlusive or non-occlusive, which means the artery or vein is not blocked, but the flow is low, and that results in mesenteric ischemia. So all of these acute or chronic, occlusive or non-occlusive etiologies will all result in a decreased blood flow to the gastrointestinal tract, which is bad. And so the clinical course of all mesenteric ischemia may range from transient and reversible to fulminant, which essentially means death in your patient. So just looking at that classification, I'm just going to run through a kind of a different schematic here. So we're talking about all intestinal ischemia, and as I say, there's quite a heterogeneous mixture of conditions here. So this little kid here out on his own, ischemic colitis, is due to reduced blood flow in the bowel, but it tends to be much more benign. Bad outcome is unusual, and generally, if I'm managing somebody with ischemic colitis, I'm quite relaxed that they'll probably be fine. So compare that with acute mesenteric ischemia, which is what will get a general surgeon up promptly in the middle of the night. This is bad, and this can lead to the death of your patient. And acute mesenteric can be due to acute occlusion of a big blood vessel supplying the intestine. It can be due to occlusion of a big vein that's draining the intestine, or it could be what's called non-occlusive. So the blood vessels, the artery and the veins are not occluded, but the flow in those blood vessels is so low that the bowel becomes ischemic, and this can be very difficult to diagnose. So of the acute arterial ischemia, it can be due to an embolism, or it can be due to thrombosis, and I'll go through the definitions of those in a little bit longer. As I said, acute venous ischemia is usually due to thrombosis in a big vein that drains the intestine. And then chronic mesenteric ischemia, we're not going to talk so much about today. We're really going to talk about acute mesenteric ischemia. So acute mesenteric ischemia comes into your surgical admission unit or A&E, middle of the night, and the patient's often unwell. Chronic mesenteric ischemia might be something that comes to the vascular clinic or your general surgical clinic with chronic symptoms. So let's talk about ischemic colitis. So I said this kid's kind of out on his own. This is a slightly different condition. It is due to mesenteric ischemia, but the clinical course is usually much more benign. So this is described as a consequence of a transient decrease in the colon, blood supply to the colon. And I think of it definitely much more of as a colitis than a major vascular event. It rarely requires surgery. The books say 20%. In my own experience, I'd be interested in Ms. Din's experience, but I would say it's probably less than 10, possibly closer to 5% of cases require surgery. It's rarely fatal, in my experience, and it usually affects what's called the watershed territories between the SMA and the IMA territories. So if you look here, it usually affects this area here in the splenic flexure and down the left colon. And it presents usually as a colitis. So it depends on the severity of that ischemia. In most cases, there's what's called a partial thickness ischemia, usually affecting just the mucosa. It can progress to full thickness necrosis of the bowel wall, and that's bad. Those patients do badly in the colon and farts. So the causes are said to be due to kind of global flow states, such as heart failure, somebody's maybe had a heart attack, consequence of sepsis or hemorrhage. So ischemic colitis presents, the patient's usually elderly, not always. The history is usually short, usually of a left-sided abdominal pain, fecal urgency. I sat watching TV, I got pain in my tummy, I went to the toilet, I had a diarrhea, and then I passed some blood-stained motion. And examining the patient, they don't usually look particularly unwell. They may have a fever. They do have sometimes left-sided tenderness peripherally in their tummy. They're not usually particularly terribly unwell. The inflammatory markers may be raised. A CT scan would show segmental colitis, and you can confirm the diagnosis with endoscopy and biopsies. And generally, it's treated with antibiotics, analgesia, and generally they get better. So this is a CT scan of ischemic colitis. So if you look here, this is probably a bit of sigmoid colon, distal sigmoid colon, and you can see the sigmoid colon's full of air. You can see that the wall of the bowel, this white enhancement, is the wall of the sigmoid colon with intravenous contrast in it. And as you see, it's nice and white and thin. Compare that with the left colon here and the splenic flexure. You can see that the wall of the bowel is very thick. Okay, so that's a segmental colitis in the region of the crossover between IMA and SMA watershed territories. This is typical of ischemic colitis. If you want to do endoscopy, you see this patchy colitis and sloughing of the mucosa, sometimes ulceration. The patches are normal mucosa and abnormal mucosa. So this is ischemic colitis on endoscopy, and then you would confirm the diagnosis with biopsy. So confirm the clinical diagnosis with CT, fitting with clinical history, endoscopy and biopsy. Usually a benign course. They usually get better over a few days. It's unusual for those patients to be admitted repeatedly. A small percentage will develop full thickness necrosis of the wall of the colon, and they will require surgery and a colectomy, and those patients tend to do badly, and they've got a high associated morbidity and mortality. Sometimes you see these patients come back, and as a consequence of the inflammation that has developed a stricture. It's pretty unusual. So let's talk now about acute mesenteric ischemia. As I said, this is the frightening condition that will get general surgeons up in the middle of the night. So acute mesenteric ischemia is a catastrophic abdominal emergency. It's characterized by a sudden interruption to the intestinal blood flow. Its incidence is thankfully uncommon. However, 1 in 1,000 of all hospital admissions, but the mortality is very high, 60 to 80%. It can be very difficult to diagnose, and it needs prompt diagnosis and treatment, or the patient will die. Time is critical, and if the patient progresses to bowel necrosis, the reasonable chance that they will die. So this is what we're hoping to not see. This is a patient who's either presented late or been managed conservatively for too long a period, and this bowel is dead. So this is widespread necrosis of the intestine. Even if this is resected, there's a very high chance that the patient will not survive. It may well be that all of the small bowel has infarcted, and apart from very rare circumstances, that usually means death. So this is a CT scan that shows air in the wall of the bowel, which is abnormal. This is the sigmoid colon here, and you can see there's no air, the air is in the lumen, but not in the bowel wall. So air in the bowel wall is very abnormal, and these stripes of gas here, they're going up into the portal venous system. So this is called portal venous gas, and this is usually a very bad sign. So again, just thinking now about the classification, now we're looking at acute mesenteric ischemia. We've talked about ischemic colitis out there on its own. We're talking about acute mesenteric ischemia. So just quickly, we're going to talk about the vascular anatomy. You've got your aorta, celiac axis is up here behind the colon. We've got the inferior mesenteric artery down here. It supplies mainly the colon, sigmoid colon, and rectum, and then the superior mesenteric artery. So it's usually the superior mesenteric arteries that are affected with acute mesenteric ischemia. You'll have a diagram here of blockage in the artery at the origin of the SMA. So we talked about the two types, or the two mechanisms of how the big blood vessel might become blocked, either with embolism or with thrombosis. So an embolism starts somewhere else in your body as a blood clot and travels through the body and gets blocked in an artery. Typically, the artery would be the superior mesenteric artery. And typically, this clot has travelled from a clot within the heart. So it's travelled and then blocked a otherwise normal artery. So the distinction here is that thrombosis occurs in situ. So this is somebody who's got big fatty plaques inside their aorta, and we get plaque rupture, and then we get blood sticking to the rupture, and then we get occlusion of the blood vessel. So this is generally a normal artery, and clot has travelled from somewhere else in the body, usually the heart, or thrombosis, which has happened in situ in an abnormal blood vessel. So if we're talking about embolus, the clot that's travelled from somewhere else, this is the commonest cause of acute mesenteric ischemia. The embolus is a foreign material that travels through the body and gets wedged in the artery, and the majority of these emboli come from the heart. The SMA, the superior mesenteric artery, is most commonly affected, and we think that's because of this relatively acute angle. The clot comes down here and then tends to slide down the SMA. So this is a CT angiogram, which is a very good diagnostic tool for looking at mesenteric ischemia. This is looking from the side. These are the thoracic vertebra. This is the aorta. It's white because it's full of contrast, which has been injected and appears on the CT scan. So here it's white, 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 and then it becomes dark. Okay, so this is the clot. This is called a filling defect. And this is a normal artery. The clots travel down until it's got so small it can't get any further, and this then blocks the artery. So the thrombosis is different. As I said, thrombosis happens in an abnormal vessel due to plaque rupture. So here we see a similar view, but here the aorta, got lots of calcification in it, which suggests long-term atherosclerosis. And here, the clot is formed closer to the origin of the SMA. So we got some flow here, but there seems to be an abnormal filling defect here and filling defect here. Okay, so generally, with thrombosis, it happens much closer in the origin of the SMA. And as a consequence of that, you lose much more intestine because it's closer to the root of the aorta, if that makes sense. So the prognosis of the consequence is worse due to underlying vascular disease and abnormal vessels and the extent of bowel involvement. So it's like the branches of the tree. Here we're losing all of the tree because it's the right of the roots or the trunk. If you get an embolus, it travels much further down and you lose less bowel. This normally happens in patients who have long-standing atherosclerotic disease, and they may give a history of chronic mesenteric ischemia, where intermittently the blood flow is decreased because of thrombosis, because of narrowing, and they get what's called intestinal angina. When they eat a meal, the blood flow reduces and they get pain. So they might give a history of that, or this might be de novo. This might be their first presentation. So we've talked about blockage of the artery through thrombosis or embolus. Now we're going to talk about the big vein, the SMV here, that travels, drains all the blood from the small bowel. So here again, we've got some very abnormal looking thickened small bowel as a consequence of ischemia. This is the artery, which has got contrast in it, which is still patent. And this is the vein, which has got a big clot in it. So this is the least common cause of acute mesenteric ischemia. We maybe see in Oxford one of these maybe once or twice a year, probably. And the most secondary to things that give you clots. So malignancy, sepsis, inflammation, or I think my experience would be in the tummy. You see it more commonly where people have inflammation in the tummy, say, for example, with pancreatitis, sometimes diverticulitis. It usually involves the segmental vessels of the superior mesenteric vein. It's unusual to get to progression to frank ischemia and necrosis of the intestine, and that progression is much slower than that of arterial thrombosis. And the mortality is dependent on the extent of the venous involvement. And often we can treat this with anticoagulants, and sometimes our radiology colleagues can do something clever in helping direct lysis to this thrombus. So let's think again about what we've talked about. We've talked about ischemic colitis out there in the zone, much more of a colitis than a major vascular event. We've talked about acute arterial ischemia, which is bad, can happen due to embolism, traveling often from the heart, thrombosis in an abnormal blood vessel. And we've talked about acute venous ischemia, usually resulting in thrombosis in a vein. So the last thing I'm going to touch on briefly is non-occlusive acute mesenteric ischemia. So in this situation, there is no physical blockage, there's no thrombosis, there's no embolus, but the patient's gut is hypoperfused. And this is the type of patient that you're talking about. They're very unwell patients who might be on lots of inotropes for another condition, such as sepsis, cardiac surgery, and you get a phone call from their ICU saying this patient is intubated, they're very sick, they've got a rising lactate, for example, and we don't know why. And this can be very difficult to assess because the patient might be intubated. You get no meaningful information from examining them, and might be difficult even to get into the CT scanner. But if they have prolonged hypoperfusion of their gut, it can develop into frank ischemia and necrosis. And in a patient in ICU, that's going to be fatal. So how might our patients present with acute mesenteric ischemia? The typical textbook presentation is of acute severe abdominal pain, and the pain is out with what you might expect examining them. So they have terrible pain, but they don't initially have peritonitis. They might feel nauseous, they might vomit. The textbooks would describe bloody diarrhea. I don't think you see that often. And in thrombosis, there may be a history of postprandial pain and weight loss. So let's remind ourselves that thrombosis generally happens in an abnormal blood vessel. They may have a long history of intermittent pain after eating because of intestinal angina. So what's happening in terms of the physiology? Well, there is hypoperfusion of the gut. First of all, the mucosa is affected with ischemia. Then we get bacterial translocation because the mucosa is damaged. So bacteria leave the gut and are circulated systemically. You get a surge response. All of our vasculature becomes leaky as a consequence of surge. So you lose lots of fluid into what's called third spaces. You lose lots of fluid, you become hypovolemic, then you become hypotensive, and then you get widespread organ dysfunction. So what's happening in the bowel? Well, progressive ischemia can lead to bowel necrosis, which can lead to bowel perforation, and peritonitis in that situation will kill your patient. So again, this is the situation that we could be looking at. So in terms of making a diagnosis, well, you need to think about it. You need to think about acute mesenteric ischemia in your old patients with history of previous clots, heart attack, intrafibrillation, arteriopaths, unexplained metabolic acidosis. Certainly I have patients who have very little abdominal pain because they're rising lactate and found to have frank mesenteric ischemia, and pain out with findings on examination. So our labs worried about our lactate, amylase, and a metabolic acidosis. And the diagnosis of choice is CT scan with intravenous and arterial phase contrast. So just to check who's still awake and who's been listening. So this is a CT scan of somebody who's presented with acute symptoms and signs of fitting with acute mesenteric ischemia, tummy pain and a rising lactate. And this is their CT scan. So we can see on the CT scan here, you've got normal blood flow on this part of the superior mesenteric artery, and then it suddenly stops. So we've got this filling defect, and we've got the same. This is a reconstruction of the same image. We've got this filling defect here. The blood supply suddenly stops. So do we think this is due to an embolus, where the filling defect is occurring? Is it quite far down the SMA, or is it proximal? Is it on the proximal SMA? So what do you think? Do we have a little poll going? So do you think this is due to embolus, or do we think it's due to thrombosis? Oh, yes, very good. Right. So the majority of people are correct. Absolutely. So it is due to an arterial embolus. And we can tell that because the clot has traveled far down here and can't get any further just because it gets stuck. If it was a thrombosis, the filling defect would be right back here at the ostia, or the origin of the SMA. Very good. Okay, so what's the management of acute mesenteric ischemia? So this is a bit wordy, but I think the 6 hours is quite a good way of thinking about it. So react. This is something that needs to get everybody out of bed and thinking about it, because we need to diagnose quickly and we need to treat quickly. We need to resuscitate, fluids, antibiotics because of the bacterial translocation. Get somebody involved early who's going to make a decision early. This isn't somebody who's admitted at 12 o'clock at night and discussed at 8 o'clock in the morning. And your patient, if they survive, will almost certainly be going to ITU. So we need to resect. So the necrotic bowel will kill the patients quickly because of translocation, perforation, and peritonitis. So if there's a dead bit, it has to be removed, and it has to be removed promptly. So if there's signs of peritonitis, an unwell patient, non-viable bowel on CT, then the patient has to be taken to theatre. If the patient is not critically unwell, they don't need immediate surgery and removal of dead bowel, then consider whether or not you may be able to improve the blood supply by sometimes resuscitation and sometimes revascularization, either with angiography or embolectomy or bypass, or particularly in with venous thrombosis anticoagulation. So then also think you may need to relook. So sometimes we take the patient to theatre, we take out what the bit we think is non-viable, but we stage a second look laparotomy in 24 hours, sometimes 48 hours, to make sure we haven't left any dead bits behind, and revisit the expectations in terms of loss of large sections of small bowel may not be survivable. So if you laparoscope or open a patient who's 82 in the middle of the night and all of the gut is dead from the DJ flexure to the colon, which has certainly happened to me, I'm sure it's happened to Miss Din, then I think at that stage you need to say, this is unachievable. Don't embark on radical extensive surgery in a patient who won't survive. And at that stage, it's the kindest thing sometimes to wake the patient with lots of analgesia, sometimes a spinal anesthetic, inform their relatives, unfortunately, and palliate them. So be realistic about what you can achieve in that situation. So this is a condition that involves not just surgeons. The job of the general surgeon really is to diagnose, manage, and resect the dead bowel before it kills the patient. The vascular surgeon will be involved in an attempt to restore blood flow. This is what's called a stent, placed in the origin of the SMA to increase blood flow for thrombosis in an abnormal artery. And our interventional radiologists, who rely on more and more and more, can restore blood flow sometimes by angiography, sometimes by directing thrombolysis into an artery, or sometimes even a vein. So I'm sorry I've gone on quite a lot. It's quite a complicated subject, but I hope that you've learned something this afternoon. And I suppose these are the learning points I'd just like to emphasize. Acute mesenteric ischemia is a true surgical emergency. You must have a high index of suspicion on the basis of the history, the symptoms, the signs, acidosis in particular, organ failure and systemic upset. You must get prompt CT angiography to establish the diagnosis. You must act quickly to resuscitate the patient. After assessing the CT angiogram, the patient should have surgery to assess bowel viability, if you're concerned about bowel viability, re-establish vascular flow if possible, and resect non-viable bowel. The employment of damage control techniques and continued critical care and resuscitation is essential, for which you mean you do hopefully a quick operation, remove the dead bit, get them into ICU, and then relook if necessary. But this is something to get the best acute care surgeons, radiologists, anaesthetists, and the vascular surgeons. Okay, thank you very much. I'm sorry I ran over a little bit. Do you have any questions?
Thanks. Thanks very much, Stephen, for a lovely and comprehensive run through what is quite a complex subject. So there are a few questions which have come through, and we'll perhaps have a look at some of those. And I think pertinent to what you just said is, when does one involve the vascular surgery team in terms of, how can one pragmatically involve a vascular surgeon, as sometimes you may not be entirely clear what the diagnosis is when you're taking someone to theatre?
Yes, so I think where the vascular surgeons are particularly helpful is where you're looking at thrombosis fire, where the obstruction is likely to be at the root of the origin of the SMA. Those patients do particularly badly, and then those would be the situations where I would want to involve the vascular surgeons, because if that patient gets widespread necrosis, they're going to lose all of their small bowel. So then the vascular surgeon may be in a position to perform a bypass of the disease segment of their SMA. So, I mean, sometimes it's difficult to work out if it's embolus or thrombosis. Yeah. But if you can resect, embolus tends to be a much more limited area of the small bowel. So if you're lucky, you'll you'll maybe lose part of the distal small bowel, but you've enough small bowel to make the patient, so the patient will survive. But with in an arterial path, with an obstruction at the origin of the SMA, the only possibility of leaving any intestinal length will be bypassed. So is that kind of enough of an answer? Would you do anything differently, Farah?
No, I think that's absolutely right. As often one often finds oneself in this position in the middle of the night, and it's unclear whether it's been necessarily a thrombotic event or an embolic event. So one of the other aspects, given sometimes the uncertainty as to what the cause is, would you normally anticoagulate patients, or in which of these conditions would you employ anticoagulation as part of your immediate management?
So, I mean, if you anticoagulate your patient, give them full anticoagulation, you can't then immediately take them to theatre. So, I think you need to look and assess the condition of the patient. If the patient is unwell, if they have peritonitis, then they have dead bowel, and then that becomes your priority. So that will kill your patient. So that patient goes straight to theatre, and you resect the non-viable bowel. If your patient is not particularly unwell, and if the CT angiogram suggests that there's venous ischemia, then I think it is very reasonable to anticoagulate your patient in discussion with the vascular surgeons. So venous ischemia, who doesn't require surgery, who doesn't have peritonitis, with a venous thrombosis, I would anticoagulate. And then the other group I would anticoagulate is the patient who probably has a thrombosis, who's got a history of intestinal angina or an arterial path, where they don't have peritonitis, where their situation is stable, where they have clot at the origin of the SMA, but you're hoping that by giving anticoagulation, you're going to break down some of that clot and restore some blood flow. But that would probably happen also with catheter-directed thrombolysis by your radiology colleagues. So I suppose essentially there are two groups there. Don't anticoagulate the person you're about to take to theatre. The person you're about to take to theatre will be sick or have dead bowel, venous thrombosis, and chronic intestinal ischemia with thrombosis would be the ones I would think of anticoagulating.
And in terms of sort of immediate management, would you place another question is, would you place all of these patients on broad spectrum antibiotics, and the rationale for that?
Yes, I would. And I would do that because, as I said, you get mucosal damage, then you get bacterial translocation, and so that's why I would put them on intravenous antibiotics.
Another sort of aspect, I mean, one of the most challenging aspects here is sort of often, making the diagnosis in a timely manner. Your presentation, you had that, CT, gives you the best potential for diagnosis. Would you always wait for a CT scan? And in terms of the sort of sensitivity of CT scanning, what are the particular features that you might look out for that concern you on a CT
Yeah,
scan?
no, I think that's a really good point, Farah. And I think I showed a couple of pictures of a great CT scan there of dead bowel with portal venous gas. Essentially, if your CT shows that, you probably missed the boat. Yep. And essentially, it is a challenge because the CT findings often are only really manifest at a later stage in the disease. So sometimes the CT findings may be non-specific. They might also be, they'll almost be reassuring. They may show that the blood vessels don't look too bad, the bowel doesn't look too bad. But I think, to come back to emphasize a point that I made, was that this requires a lot of clinical suspicion. It requires senior involvement because these cases are difficult to diagnose. But certainly I've been in the situation where I've had a patient with not a good history, but simply a rising lactate. One or two concerned senior clinicians have been woken in the night by the anaesthetist who said, I think this chap's got ischemic bowel, he's got a relatively normal looking CT, and we took him to theatre. So I think you need senior people involved, you need a high index of suspicion. Ideally, you would have a good history, a rising lactate, and CT findings. But generally, you might act on just one of those. And certainly, I would, if I was concerned, I would just take the patient to theatre and perform a laparoscopy. I think that's actually probably one of the most sensitive things to do. Would you do
Yeah.
anything differently?
No, I think absolutely, as you've said, high index of suspicion. There isn't any particular blood test that is diagnostic, and you can use a lactate, you can use an amylase. The majority of these patients will have a raised white cell count. As you know, there may be some role, for D-dimers in the mix, but at the end of it, it sort of boils down to your clinical suspicion and what the patient is like and what your experience is like. And that's why senior involvement early on is good. We'll maybe finish off with one last question. And Stephen, you slightly alluded to this, that sort of in days gone by, we would have open and close cases where all of the small bowel is dead. And is there a role in these cases, in fact, for exteriorizing ends with a view to small bowel transplantation? Is that something that one, may consider in certain patients?
Yeah, absolutely fine. I think that's a really good point. I think we thought maybe maybe a little bit beyond the scope of my initial presentation, but yes, I mean, I think of the people that we see far, unfortunately, many are elderly, and the ones that survive were the ones who have limited small bowel resection, and even it's difficult to get them through. Unfortunately, I mean, my experience is patients with widespread small bowel and sometimes colonic ischemia won't survive. There are, yes, absolutely, a very small subset of patients where you might perform very radical surgery and remove most of the small bowel and the colon. I think those are highly selective. I think the patient that I would consider in that situation essentially would be young patients who maybe had a massive embolus from their heart.
Yeah.
And yeah, it is possible. I think probably in my experience, I've maybe seen 2 or 3 who survived. Only one went on to have a small bowel transplant. Interestingly, we're doing some small bowel transplant here in Oxford, and that's probably actually the commonest indication, because those patients have a massive embolus and they're otherwise, cardiovascularly fine, and they've got no other comorbidities, and those are the ones that have quite successful small bowel transplants. So yes, would it be great if we could offer it to more people? Absolutely, but I think it's still rare, isn't it?
Absolutely agree. But perhaps, in previously we may not have considered it in all patients, and a limited role in some select patients. So I think we probably need to draw things to a close. Final sort of question from me. I mean, do you see us attaining newer diagnostic tools where we might be able to diagnose bowel ischemia either through imaging or other biochemical manners?
I'm not aware of any, to be honest. I mean, it would be nice to have a better way of looking at perfusion, wouldn't it?
Yes.
Whether or not CT scanning might become more sensitive. But essentially, CT scanning is quite crude, isn't it? Essentially,
Yes.
you're injecting a contrast medium and then hoping to see it on a scan. So whether or not there are better ways of looking for perfusion, I think that would be the most sensitive, because essentially, apart from that, essentially we were looking for quite blunt indicators of mucosal damage, aren't we? We're looking at
Yes.
We're looking at acidosis. We're looking at inflammatory response, and those things, and actually come, and then systemic upset. And those actually things come quite late down the physiological pathway.
Yep.
It is, but you're right. Even I mean, we haven't seen huge advances in, I think, in the treatment of this, or certainly in the diagnosis of this condition in my surgical experience. Are you optimistic, Farah? Will people do better in the future?
I'd like to think so. That absolutely emphasizes, hopefully for all of the budding surgeons out there, emphasizes the role of trying to take a good history, doing a good examination, and putting those pieces together with the diagnostic tools that you have available, because there isn't anything that is absolutely diagnostic and then working in a timely manner. So I think we'll draw things to a close. Thank you very much to Stephen Boyce for a fantastic presentation. Thank you to all of the audience for the questions. We've tried to get through as many of those as we could. And just to say that the next lecture in this series is an introduction to bariatric surgery. I didn't think I'd necessarily be advertising that, but Tuesday, the 11th of June, 2020 at 4 p.m. And so please join us all then. And thank you to the Royal College for supporting these webinars. Thanks again, Stephen.
Thanks very much, Farah. Thank you.
Bye.